speaker, Dr. G. Sridhar, to talk about heart failure with reduced ejection fraction and the principles of optimizing therapies.
Thank you. Thank you for the invite, sir. After that lusterful pictorial presentation, my presentation is more of a theory, maybe dull and boring. But I think there is a lot of learning, because heart failure is actually a combination of preserved and reduced ejection fraction. Most of the patients which we see, though there is equal distribution of preserved ejection fraction and reduced ejection fraction patients, the highlight is of reduced ejection fraction, I should say. And most of the times when we are treating as physicians, the diagnosis of heart failure is made, the future is gloomy, but we have to do something in those set of patients to make their future a little bit more brighter. So my topic is optimizing the therapy. We know that, we all know as physicians what are all the components of heart failure medicamentarium. So what are the goals? The major goals of heart failure treatment, or for that matter any disease treatment, is reduce morbidity and mortality. That's very, very important. All of us have to strive towards it. Heart failure has innumerable causes, which I'm not going to elaborate. Identify the cause of heart failure and associated conditions. It can be as simple as diabetes, it can be as simple as coronary artery disease, valvular heart disease, hypertension, so on and so forth. And it is a chronic treatment, it's a lifelong treatment. It is very important to involve the patient in therapy, educate the patient about what is heart failure, and involve him in self-care. That's very, very important. So he can adjust the medication himself, including dietary therapies, nutrition, etc. And some of the patient may be very active, and when once heart failure sets in, his activity level may come down. So it is very, very important to rehabilitate the patient also professionally. Some patients are extremely sick, palliative care may be needed, and some patients out of the heart failure component of patients are suitable for device therapies like AICDs, CRTs, CRTD, which are going to improve the quality of life as well as quantity of life, subsiding the morbidity associated with that. You have to select such patients, and certain patients are very sick, still want to survive. Maybe they are looking for some support in them, the mechanical assist supports, some left ventricular assist devices, maybe the heart-made therapies, in order to bridge them to final goal, that is heart transplant. These are all the components where you have to look at when goals are there. The general management, of course, points down to an individual patient. Very important to have risk factor control like diabetes. And we all know that one of the treatment of diabetes in heart failure patient should be an SGLT2 inhibitor. Hypertension therapy also becomes very, very important, and I dwell upon some of the hypertensive agents which are helpful for heart failure therapy as well. Ischemic heart disease, one of the very common causes of heart failure. It should be looked into, and wherever possible, revascularization should be offered in the form of any therapy which can improve the blood flow to the coronaries. Valvular heart disease is another area which can be potentially treated, and look into the cardiomyopathy aspects. We saw how sarcoidosis, amyloidosis, these are all spectrum of diseases. Some of them may present with preserved ejection fraction, but majority of them may present with reduced ejection fraction. Potential therapies, identify cardiomyopathy, evaluate and treat. Renovascular hypertension, which is a very important component which may ultimately lead you to heart failure with reduced ejection fraction. Identify it right time and treat it. Nowadays, newer therapies with renal denervation is also available. And arrhythmias are a part and parcel of any heart failure, more so in heart failure, reduced ejection fraction. There is conduction system disease, heart blocks, atrial fibrillation. Identify and treat them and optimize the therapies. And most important, most of the heart failure patients in our country, a developing country, have anemia of chronic iron deficiency. Look at it. Coming to the most important, pharmacology. How did we come to this? There are armamentarium of trials. If you look at it from 1986, we are entering into almost 30 years now. The medical therapy came out of this trial data. The majority of the trials were on 4 basic groups of medications, that is the ACE inhibitors, ARB, on the ARNI, which is replacing them, beta blockers, and mineralocorticoid receptor antagonists. Of course, there are some trials on device therapy and some trials on revascularization like stitch therapy. There are some trials also on newer agents which are there, which have come in 2020, 21, like the vericiguat, and also the therapy on iron replacements like carboxymaltose, etc., etc. So our knowledge of medical treatment came of these magnitude of trial data. So with this support, we came to the conclusion that all heart failure patients should be on this quad therapy, we call it as. What is a quad? That is a combination of therapy which involves ARNI, beta blockers, mineralocorticoid receptor antagonists, and SGLT2 inhibitors. Always to be used as a combination therapy. This is a message which we have to give. Though individual drugs have proven their efficacy in heart failure, the efficacy is quadrupled when you use them as quad. What is the advantage? If you detect a correct patient and put them on quad, you are going to add 6 more years to his life when you have diagnosed a heart failure patient at 50-year-old. But what is happening? Despite of 3 decades of evidence available with these armamentariums, one by one or sequentially, we have failed in utilizing this and putting all our patients onto these quad agents. There is gross underutilization of guideline-directed medical therapy in a country like ours. Why? The common concoction is, see, my patient is not tolerating this drug, this is side effect, some allergy, this, that. But in spite of the absence of intolerance or contraindications for such therapies, still there is underutilization. And there is very slow uptake of these therapies. There is presumptive sequential medication thought. We all know that once, whether it is hypertensive therapy or a diabetic therapy, let us treat with one agent with full dose and then add the other agents, which is the norm which we have adopted, which is actually false. And we should all consider ourselves therapeutically very lethargic to initiate aggressive treatments. And there is also a very big delay in optimizing the quad. If you use a sequential therapy format, to introduce all these 4 drugs may take months, even a year. Why it is important? It is very important, but all these drugs have proven their mettle within 2 to 4 weeks of therapy. For example, if you see in DAPA trial, with introduction of dapagliflozin, the therapy benefit was seen in 2 to 4 weeks. That's very important. So also is the case in acute decompensated heart failure therapy, where ARNI was introduced in Pioneer HF and it showed its mettle in 2 to 4 weeks. It's very, very important because the therapy with quad therapy, the response with quad therapy is going to come very short, in a very short span of time. There is no need to wait. And there is also a thought process that I should have a proper background therapy patients. The patient should be on proper medications before I add on a new therapy. It's not very, very important. For example, if you see in a paradigm heart failure trial itself, which is the mother of all trials, only mineralocorticoid receptors were never in all the patients. If you take it into beta blockers, maybe proper number of patients were not on full dose of beta blockers at all. So is the case of use of ARNI in DAPA-HF trial. When DAPA-HF trial came, in subset of those patients, the ARNI utilization was only in 10.4. So it's not very important when you are starting the patient on quad therapy to see that whether your patients are on other 3 drugs before you introduce the 4th drug. That is very important. Introduce all the drugs irrespective of whatever the patient is on before, whether optimized or unoptimized. And there is also a common thinking process that more and more higher doses is going to give more and more therapeutic benefits, which is not true. In the HEAL trial, there was a subgroup analysis with low dose losartan and high dose losartan. The high dose losartan only reduced mortality, but there was equal benefit as well as morbidity is concerned in the HEAL trial. So was the case with lisinopril in ATLAS trial. So it's not very important for you to say that I should reach the guideline directed dose only to reach the benefit. It's not so. Even at smaller doses, each of these drugs are going to give you the benefits. And in MERIT HF trial, only 60% of the patients reach the target doses. Other 40% also derived the benefit. So it is not very important that you reach the maximum dose as per the guidelines to derive the benefits out of those drugs. Because the higher doses may result in more side effects and you may withdraw the drugs, thereby undermining the need of giving all the 4 drugs. In the EMPHASIS trial, lower doses of eplerenone was equally efficacious. So there was no need to escalate the doses. And in PARADIGM trial, there was equal benefit on patients with lower doses of ARNI also. And SGLT2, for your information, has only one dose. There is no dose escalation at all. And collective introduction of these medicines is more important than sequential. And in lot of ACE trials, the doses, smaller doses have given big benefit. Don't aim for the therapeutic doses at all. So how to initiate the strategies? How to see that all these drugs are introduced and pushed to prevent underutilization? The consensus now, therefore, is rapid escalation of all these therapies. Introduce them at once. But it is not very easy. It is challenging. So what is required is newer strategies. So people came up with these three thoughts. The middle one, the Miller one, they thought, you see the patient with heart failure and strategize your therapy. For example, if your patient has come with high blood pressure, start him on ARNI, which is also a very good, powerful blood pressure regulating agent and also a mineralocortical receptor blocker. If he has a higher heart rate, he has coming up, introduce beta blocker. If he has coming up with volume overload, introduce SGLT2. This is the thought process. There is another thought process also, that initiate all patients at presentation with SGLT with beta blocker. So if there is volume overload, if you initiate them with SGLT2 and beta blocker, the diuretic effect will set in. So that at 2 to 4 weeks, you can initiate ARNI and MRA and sequentially escalate. There is another thought process of rapid initiation of all these drugs at low doses and then escalate it at 2 to 4 weeks. But of course, all of this comes with a catch. You decide, you are a physician, you decide what you have to do. Rapid mortality and morbidity benefit will come in 2 to 4 weeks. It has been very well adjudicated in lot of trials. Each of these drugs have additive benefits. In the absence of particular contraindications, it's very important to add all these 4 drugs. And there is another endpoint, hospitalization. It's a very bad endpoint we see in all heart failure trials, but it's not. Actually, it is a blessing in disguise. You have a patient in hospital, catch hold of him, start all these therapies, and you know why it is very important? We are so lethargic, whatever your discharge medication goes, it goes on forever. There is hardly going to be any change in our medications, even at 1 year follow-up, as is proved by the Connect Heart Failure trial, where they said that there was no change in medication. So if you initiate medications at your hospital, you are going to continue them. So it's a boon. And a few case scenarios, if it's a chronic stable angina patient, chronic stable heart failure patient with CKD and a stable diabetes, initiate an ARNI at lowest dose, replacing ACE and ARB, initiate SGLT2. You expect GFR to fall by 20% in 2 to 4 weeks. Don't worry, consider adding MRA if your potassium levels are stable, considering adding beta blocker and titrate it at 4 weeks. If you have a decompensated heart failure, just follow Pioneer heart failure model, replace ACE-ARB with ARNI sooner when the inotropes and IV diuretics have stopped. Safe to initiate SGLT2 which kick in with diuretic effect. And if your patient is very sick, you can add in the 5th pillar which is coming up, that is the vericiguat at 2.5 milligram, and you can escalate the doses. Because vericiguat has proven to be of big benefit in sicker patients of heart failure. If you have a stable de novo heart failure, reduced ejection fraction patient, rapid and sequential initiation of all the low doses therapies, low dose ARNI, low dose beta blocker, add MRA at 2 to 4 weeks, add SGLT2 inhibitors, follow with electrolytes, start uptitrating at 4 weeks, evaluate and assess these patients for further therapies. So this is in nutshell the combination of same things. The most important thing is never withdraw the beta blocker. Beta blockers are the only drugs which have proven to be at higher doses helpful in bigger mortality relief. Try and stay put with beta blocker. Try to add ARNI at appropriate times and also substantiate it with mineralocortical receptor antagonist and SGLT2, and try and start escalating the doses to the maximum tolerated doses by around 4 to 6 weeks. This is again the same thing. Most important thing is to continue the beta blocker. In the hospital, try and initiate ARNI and SGLT2, and by 4 weeks at least, all these patients, whether it is chronic heart failure, whether it is acute heart failure, or whether it's a de novo heart failure, should be on these quad agents. So there are what are called anticipated side effects. Hypotension is a big side effect. The most important thing is to assess the volume of the patient, cut out your diuretics, and space your medications at different times so that hypotension will not come. The worsening GFR is another thing. If anticipate that and adjust your diuretic and medications, and hyperkalemia, we have now agents to treat. So much so the recommendation is to give potassium binding and continue MRA and ARNI. Fifth pillar, where you got a small word, now the effect is coming. We have been using this drug, though our experience is less, is found to be useful to prevent morbidity and mortality. No heart failure reduced ejection fraction comes out without mentioning this drug, but the toxicity of this drug digoxin is such that it negates its benefits, but definitely found to be useful in heart failure in those patients where there is atrial fibrillation and not otherwise. Anemia and iron deficiency, a small touch. It's a very important thing to look in heart failure reduced ejection fraction patients, because in these patients it's a chronic inflammatory condition. Your erythropoietin is not going to work. The substituting erythropoietin in such patients is not going to be helpful. Identify whether the patient has anemia. The simplest thing is to see the ferritin, because ferritin is an acute phase reactant. It may be elevated because of other reasons. In heart failure, if it is less than 100, saturation, transferrin is less than 20%, give intravascular iron therapy to enable morbidity benefit, though there is no mortality benefit. Take home, general management of the causes of heart failure, the etiology of congestive heart failure is important. Dietary education and supportive treatment for the patient is also important. Initiate quad at guideline medicated doses and up-titrate as early as possible. And withdraw unnecessary medications like amlodipine, some other calcium channel blockers which are not proven to be any benefit. Avoid stopping withdrawing quad for trivial reasons, and troubleshoot some common side effects. Refer complex cases to somebody who is better than you. Thank you.